Hello and welcome everyone to another video about our clinical rotation series. Today we're going to discuss emergency medicine. Just before we start, a quick introduction. My name is Selma Mutari. I'm a qualified GP in the Northwest area, and today I'm going to take you through what all you need to know in emergency medicine in the NHS. So this is what we're going to be covering today. It's basically what we do every single time. But today we're going to speak about a few new things such as datics and basically the dress code, which we haven't really discussed much in our previous seminars. So just a quick look at the rota and how it looks like in emergency. So you might feel that when you start your emergency medicine rotation, the rota is all over the place, and it's definitely true, unfortunately. So you have your long on-calls, which are either 12 or 9 hours. Usually in most trusts, emergency medicine night shifts are 8 to 9 hour shifts. And they're not the long 12-hour shifts that you usually do in medicine or in surgery, but there are some exceptions. So have a look at your rota before you start. Some trusts, they just do the 12-hour, normal 12-hour shifts. So in some of the Northwest areas, which where I'm originally working at the moment, we do 9 hours. So we start at 11:30, we finish at around 8:39 a.m. in the morning. This is for your night shift, which you can see in week 1 in blue. And then you have your twilight shifts, which are the ones that you can see in week 2 and week 14, and some of it is in week 4, and this is the one outlined in purple. This is your 4 to 12-hour shift. Sometimes it's 2 to 10. So again, it depends on the trust and depends where you work, but it's basically a midday shift that covers 8 to 9 hours. And then you have your regular day shifts, which are all outlined in red. And this is going to take most of your rota. So the ones 8 to 5, 8 to 4, these are your day shifts. Then over the weekend, sometimes the shifts run a bit differently. So over the weekend, if you can see in the color in gray and the one in orange here, I think it's yellowish. Anyways, so you have your 12 to 12 shift or your 8 to 8 shift, and you also have your 10 to 10 shift. Again, it depends on the trust, but usually what they do in weekends is they run 12-hour shifts. So again, 12 to 12, 8 to 8, 10 to 10. This is how the weekend operates. And then your normal twilight, mix of long, mix of day. This is how your rota usually is in A&E. So it is all over the place, really. And if you're working in different sites, so in some trusts you might work in 2 hospitals, then you're gonna have sometimes you have different hours in the other hospital. But overall, this is an outline how it looks like. Now, we've never discussed breaks before. And just for you to quickly know what your entitlement is. So if you're working an 8 to 9 hour shift, you're entitled to a 30-minute break. If you're working a 12-hour shift, you're entitled to a 1 hour break. Now, usually the breaks are preferably to be divided. So you're not going to take a 1 hour shift continuously, but in sometimes there is an exception, especially when you're doing night shifts. So you can take a continuous 1 hour break. Some people use it to sleep, some people use it to eat, so it doesn't really matter what you do on your break. Now, the question is where to take the breaks. So different trusts have different places, but usually overall we have the mess room, which is the doctor's room. We have the cafeteria if you're going to go there and eat. And usually the cafeteria does serve food in normal working hours. So from 8 to 5, you might find something to buy there, but usually after 5, 4, the cafeterias are closed. Then you have the staff kitchen area. If you're wondering where to take your night break, in some trust, if you're going to sleep, there are the sleeping pods for doctors around the hospital. So this is where to take your breaks. Now, as we've discussed before in previous videos and in our previous live seminars, it's important to know your rota in order to plan ahead and to plan ahead your leaves as well. So we've mentioned these leaves before. So we've mentioned annual leave, which is usually 27 to 32 days, depending on your experience in the NHS. We've mentioned the study leave, which is around 30 days, including your teaching days, which takes it out, and then you end up having 11 to 12 days. So if you're a trainee, You're going to have in total 11 to 20 days all over the year. You shouldn't be taking them at one go. Again, you have to divide them according to your rotations. If you're a non-trainee, however, this differs because you don't usually get teaching days. So your study leave, it depends on your contract and it depends on the agreement with your employer. So make sure it's in your contract before you sign it. Now, your sick leave is 30 days paid, 30 days half paid, 30 days unpaid. Again, this differs according to your experience in the NHS, and it doesn't really change whether you're full-time or less than full-time, but what changes is your annual leave and your study leave. So these ones, they reduce if you're less than full-time. Now, coming to maternity leave, we've mentioned it in our very first seminar when we were talking about introduction to GP training. But in maternity leave, you're entitled to a whole year, but it's not all paid. So you have 8 weeks of paid leave, 18 weeks of half paid, 13 weeks of just the maternity pay, and then 13 weeks being unpaid. And again, as we mentioned before, the maternity leave can be divided between you and the dad or the partner. But usually the mom takes most of the leave. With the paternity leave, you're entitled to two weeks. But if your spouse wants to divide the leave with you, then that's another story, really. Now, there's other kind of leave that we've never mentioned before, which is the compassionate leave. This is used in very difficult circumstances, mainly, unfortunately, if someone passes away that's close to you, like a close relative, then you take 3 days. This is including the funeral day. Now, again, this is something that you can agree on because I know a lot of us are IMGs. We have family outside. 3 days would not really be enough to book a flight back and forth to the UK. So again, it's upon agreement, and sometimes you can take authorized paid leave in order to attend such circumstances and such events. So ask, it should be in your contract again, but this is overall the overall guidance that we go with. Now the bank holidays are usually off or they're paid back. So if you're working on a bank holiday, which is like the national holiday in the UK, for example, Christmas, then you need to get this day back in lieu, which means you get an extra annual leave. So let's say your total entitlement is 27 days, but you worked on the Christmas day. So you get this day back. So your total entitlement for annual leaves comes as 28 days. So the more bank holidays you work, the more time you get back as annual leave. If you've not worked the bank holiday, you're just taking it off as usual, you don't get the time back. I hope this makes sense. Now, having discussed the leaves and everything, before you start your rotations, you need to know who your supervisors are, especially if you're a trainee. Now, when you're a non-trainee, you still have a supervisor, but it's usually just an educational supervisor. When you're a trainee, you have two supervisors, educational and clinical. And why this matters because every one of them does a different job. Now, educational supervisor, as we said before, is in your whole training years. So whatever training you're in, you're going to get an educational supervisor who's responsible for you throughout all your training. Your clinical supervisor is the one that's responsible for you in certain rotations. So let's say you're doing your GP training and you're starting with emergency rotation. So you're going to have a clinical emergency consultant supervisor who's going to be with you on day-to-day basis or week-to-week basis. You're going to see this doctor in the ward, in the department, more frequently than your educational supervisor because as a GP trainee, your educational supervisor is in the GP practice, so you're only going to be seeing the educational supervisor in your ST3 year or when you're doing the meetings or teaching days to meet your educational supervisor. So who to go to for general advice about your portfolio would be your educational supervisor. Who to go to for your day-to-day rotation advice or clinical cases, it's your clinical supervisor. Okay. A question that we've been asked a lot is what to wear here in the UK when working as a doctor. So it differs according to where you are, but overall in A&E, we usually wear scrubs, and these scrubs are provided by the department. So you don't need to buy your own scrubs, and most of the time you don't need to buy your own scrubs. You're given the scrubs, which are different colors in different departments. Now, I used to work in Lancashire Teaching Hospital, and we used to wear like a green scrub kind of a green color. It's like a light green. In some trusts, you can wear like a blue scrubs. In other trusts, you might wear like a beige color. So it depends which department and which trust you're in. But overall, the dress code, especially in A&E, is scrubs. And there's a certain way that they like to do it here in the UK. So you should be bare below the elbows. So anything below the elbow, you shouldn't be wearing anything, especially accessories, watches. The only exception is your wedding ring or engagement ring. Um, your hair should be tied back, especially if it's long. If it's like around your shoulder length, then it should be tied back. You should always be wearing a closed shoe, so nothing opens like slippers, sandals, anything like that is not allowed. You should be having minimal makeup, no nail polish. Nails should be short and clean. So this is the overall standard that they would expect. Question is, does anyone like actually look or have a look at what people are wearing? Yes, they do. Sometimes there are like the word managers, they would comment on your dress code. So make sure it's nice and tidy. Make sure it goes with your trust guidelines, just because for your safety and for patient safety mainly. Before you start in any rotation in the NHS, you're going to be expected to have an induction. Induction usually runs 1 to 2 days, sometimes 3 days maximum. And it takes place at the very first week. So the very first 1 to 3 days in the department. It's a quick introduction about staff members, a quick introduction how the department runs, what is the expected jobs from you, and who to ask for support or who to ask if anything goes wrong. This is what the induction usually is. In some trusts, they offer shadowing during the induction period. So just ask if your trust does offer shadowing. Sometimes the shadowing can run as long as 2 weeks. It's not common, however, but ask before you start, especially if you're quite new to the NHS. So if this is your first NHS job, it wouldn't harm for you to ask for a shadowing period. Now, in A&E, what is your responsibilities or the jobs expected from you? So you're expected to see and clerk patients. This includes diagnosis and starting management. You might be expected to put cannulas in, take bloods, suture, do certain, hand skills like nerve blocks, but these are usually done under supervision. So anything like nerve blocks, lumbar punctures, all these clinical skills are usually done under senior supervision, even if you have the clinical experience. So at least the first time, it will be supervised. Okay, so this is overall your responsibilities. Now, what's different from A&E, what's different from the A&E department from other departments or rotations is that you don't really have ward rounds. What we normally do is that we see the patient, we clerk them, and then we take a decision whether this patient is going to be discharged or going to be admitted to the hospital. And this is where your job ends, basically. So when you're first picking up a patient, when you're first getting the triage notes or seeing the triage notes on the computer, you need to assign the patient to your name. So whoever patient you're going to pick up, you're going to put your name under them so everyone knows that this doctor is seeing this patient. Then you're going to start with your history taking. So, the presenting complaint, onset duration, associated symptoms, just as we normally do on a day-to-day basis. You're going to fill in the past medical history, medication, social, and so on. And then you're going to do your examination bit. And then afterwards, you're going to say your impression or your differential diagnosis. And then you're going to put a management plan. Don't forget senior review. And don't forget that when you're new to a department or when you're new to the NHS, you're expected to discuss every case. And then you're going to do the mandatory senior review cases. So there are certain cases, even if you're someone who has experience and even if you worked in this department, there are certain cases that you need to discuss with your seniors, such as, for example, pediatrics. Any kid below the age of 5 needs a senior review or discussion before you take a decision. Okay? So you can put your own plan, but then you have to discuss this case. For example, chest pain in certain age needs discussion. Abdominal pain, for example, 70-year-old and above needs discussion. It differs from trust to trust, but this is the overall guidance. So you would know in your induction period, they're going to tell you what cases need senior review. People that have attended, like recurrent attendance, within a 72-hour, 48-hour time span, again, they need a senior review. So this is just the overall guidance, but as I've mentioned before, it is usually discussed in the induction period. And if you don't know, please ask. You can see it on a computer system if you're using them. So sometimes when you're filling in the clerking, then it asks you at the very bottom, have you discussed the case? If it is 1, 2, 3, and you need to say yes or no, and then you need to put the senior name on it. So things are going to be quite clear to you, so you don't have to worry or panic. Everything is usually told, and you have all the information before you start in the induction period. And most of the time, emergency departments in the NHS are known to be very well supported. So it's quite easy to work in emergency department because of the support that you get. Now, I'm going to show you an example of a triage sheet. So this is how a triage sheet looks like. So triaging is basically that when the patient walks into the emergency department, they get triaged by the nurses in the reception area, and they take a brief history. They take the patient's vitals, the patient's contact, patient medication, stuff like that are usually written in the triage sheet. So when you're picking up the patient, you're going to know exactly what the patient is coming with. You're going to see a short history taken by the nurses. You're going to know exactly where the patient vitals are at. If the patient example needs to be urgently seen, if the patient is stable, that really tells you how the patient is. And of course, you have the contact number because in some cases, when you call a patient in, they're not really there anymore for whatever reason. For example, they've left, they're in the bathroom, they're buying something. So at least you have the numbers to call if you shout out the patient name and no one responds. So this is how it overall looks. As you can see here, you can see the triage time, so you can see when the patient arrived, so you know how many hours the patient has been waiting, and then you can see the presenting complaint. It depends on the presenting complaint. They can fill in other stuff, like you can see the pain score. You can see the last part here, which says the triage notes, and then the vitals in the right hand bottom side, the blood pressure, the pulse, and then they give the patient a new score. So this is how the triage sheet looks like. Most of the time it's a paper form. In some trusts it operates on a computer. So you open the triage on the computer and you have a read for all this. And then again, you assign your name and you see the patient. So if you're new to the NHS, I think it's important for you to know what the NEWS score is. So the NEWS stands for the National Early Warning Score, and it's basically the score that we give according to the patient vitals. So this happens at triage. It's usually done by the nurses, and they're quite good at doing this. So they assess the patient, and they give them a certain score. And why is this important? Really for two reasons. First, to assess the severity of the case. So to assess if this is an urgent case that needs seeing right away, or it's someone that can wait. So anything that goes around the green-gray area, this is someone who's stable, they can actually wait. Anything around the orange and red marks, then this is a bit of an urgent matter and needs to be seen immediately or within a certain time span. Now, another important thing about the NEWS score is that it tells you if this is a patient that needs to be seen by a senior or can be seen by a junior. Because any person scoring anything above a 6 or a 7 should be really seen by a senior and not by a junior doctor. Now, again, different trusts have different guidelines, but overall it's a score of a 6, 7. It needs assessing by a senior and not by a junior doctor, because this shows us that this patient, first of all, is a severe case. Second, that they might be deteriorating at any point. So it's better to be assessed by someone who has more clinical experience, really. Now, when you see the patient and you've done the clerking bit and you've done everything that needs to be done, started management, you need to take a decision where this patient is going. So you need to take a decision, is this patient going to be admitted or this patient is going to be discharged? These are the questions that you need to ask at the end of your consultation. Is the patient for admission? Then the patient needs to be referred to the right department by calling their on-call doctor. So you're going to pick up a phone, you're going to dial the number that you need to dial for referrals, for admissions really, and you're going to refer the patient to them. Okay? Once you've done that, you have to mark that the patient is for admission, and then this patient goes under the team. So for example, let's see, I've seen a medical case, and I've reckoned that this patient needs admission. Let's say for chest pain, patient turned out to have a non-STEMI, he needs admission under the medical team. So you start your management, and then you do your referral, and then you put the patient under the medical team, because then they'll need to be clerked and seen by the medical team as well. You have to start your management anyways, regardless of what department the patient is going to. Unless it's a very specialized thing, then you're going to need advice from this department, but otherwise you should be starting your management. Let's say this patient is for discharge, then what you need to do is that you need to fill in your discharge summary, give the discharge medications, and then discharge the patients. Either case, if the patient is for admission or for discharge, an ED summary needs to be filled in. So this is a summary that goes to mainly to the patient's GP that tells them exactly what happened during this visit and if the patient has been admitted or discharged and what management has been started. Anyone can access these records, not only the GP, but it's mainly for the GP's attention. Okay. If you can see the 4-hour target that I've written here, it's just for you to know that most of the A&E departments operate on a 4-hour target. So the aim is for the patient to be triaged, seen, assessed, and a diagnosis and a decision has been made within a 4-hour time. Unfortunately, due to problems with staffing, it is rarely the case, to be honest with you. So it's rarely that a patient is triaged, seen, and assessed and managed within 4 hours, but there is something called the 4-hour target. It's just for you to be aware, because if they mention it, you would know what it means. It means that the patient needs to be assessed within 4 hours. Okay. So I'm going to show you how, in the next few slides, I'm going to show you how discharge looks like so you would know exactly what you might encounter. But overall, if you're discharging the patient, as I said, you need to fill in the discharge summary. And then you need to decide if the patient is going to be referred outside. So let's say I've seen a patient. This patient doesn't need admission, but the patient needs to be seen in an outpatient clinic. So let's say I've seen a TIA case. A TIA case needs to be seen in a TIA clinic, but this patient doesn't need to be admitted. So again, you fill in your discharge summary as normal, and then you do the referral for the TIA clinic. So you're the one who's responsible for doing any outpatient clinic referrals if the patient is not for admission. So let's say a fracture clinic, your TIA clinic, any hot clinics that are operating, you do the referrals. If it's a computer system, you're going to do it on the computer and then press submit. If it's a paper form that you're going to fill the paper form, make sure the secretaries or the reception are scanning it and sending it through. Okay. So when you're discharging a patient, if there are leaflets around for advice, you can give it to the patient. So for example, a patient had a head injury and you just need to give them, the safety netting for what sign and symptom to look out for if it happens to come back, then these leaflets are really good for such stuff. So if there's any leaflets, use them wisely, give them to your patient before discharge, and make sure you document that you've given these leaflets and you've safety netted the patient. Let's say this patient is not for discharge and it's coming at the very end of your shift. Then you need to hand over this patient, but you still need to fill in the ED summary. Why? Because you're the one who's seen this patient and you're the one who knows the history. So what we call it a partial filling in of the ED summary. So you fill in all the bits about the history management, but you relieve the parts where, for example, the disposal, where the patient is going to go, if the patient is going to be admitted or not, you leave it towards the end. And you just hand over to your colleagues that are coming to the new shift. Okay, so don't need to panic if you've come towards the end and you've not really finished clerking the patient. However, if it's something that you can do within like 10, 20 minutes, then I would say please do it yourself and just sort out the patient. But if something that you feel like it's an hour, 2-hour job, then just hand it over to someone else. Okay. This is how a discharge summary note kind of looks like. This is the best that I've found over the internet because you can't really find them much when you look for them. But if you're doing computer system, you're going to see a template that looks like this. You're going to need to write what the reason of admission is. Some stuff are automatically put in. You don't need to put them in yourself, like the admission date, patient's medication, discharge time. All these stuff are automatically put in by the system. What you need to put in yourself is the reason for admission, the diagnosis, Any medication that the patient is going to be discharged with, you're going to put it in. If there's any action for a GP, as you can see here at the very end, action for a GP, you need to put it in as well. The patient is a discharge destination. Is it for home, for admission? All this he needs to fill in. And as I've mentioned before, whether you're admitting or discharging the patient, ED summary needs to be done. And as you can see at the very bottom right side, you're going to see send to GP, print, submit, save. There are different terms for it, but overall, you're just going to save it, send it, and that should be it. It should be on the system, and it should go to the GP. So how does the GP see this summary? It kind of looks something like that. So you're going to have the patient's name, address, all sorted out. You're going to have the hospital that the patient was seen in, also written in. And then you're going to have the admission diagnosis or reason for admission. So your GP is going to be able, the patient's GP is going to be able to see why the patient was admitted. And then they're going to see the plan. So at the bottom, you're going to see the medication, the discharge plan. If there's any action needed from the GP, please make sure to write it in details. So for example, repeat bloods in 2 weeks, repeat bloods in 4 weeks, do this, do that. Whatever you want the GP to do, just make sure to write it in the action plan. And this is how overall it looks when you get it as a GP. So if you're a GP trainee, you're going to get a lot of these letters that needs reviewing and then taking a decision according to them. So just familiarize yourself with how things look like so you would know what you're expecting once you start your job in the NHS. Now, haven't spoken about the discharge referrals. The only time you need to hand over a case is really when you're doing the referral and when you're handing it over to your colleagues. So if you're doing a referral for admission, handing it over at the end of your shift, then that's when you need to hand over an A&E. Now, when you're handing over the patient, you don't only hand over patients that need something doing, you also hand over patients that have already been clerked and assessed and their destination has been sorted out. Just because we know these patients, they actually stay in A&E for a while. Sometimes they even stay in A&E for a day or two until beds are free on the ward. So that's why you need to hand over these patients because they're still in the ward, in the department. Okay, so as we've mentioned before, the SBAR approach is how we do it in the UK. So you start by mentioning your own name or department if you're doing a referral because they wouldn't really know where you're calling from. You're going to mention the patient's condition. So for example, I'm calling regarding a patient. I need to refer a patient. I'm one of the A&E doctors. My name is Dr. Motari, for example. I need to refer a case of abdominal pain. Okay. And then the person that's taking your referral is going to ask you a few questions anyways. So you're going to start by giving the history. So you're going to start by giving the presenting complaint and a bit of a history of presenting complaint, what has been done for this patient so far, what you expect the diagnosis is, and why you're referring this patient. So let's say I'm referring this patient with abdominal pain, I'm clearing appendicitis, and that's why I'm referring this patient to the surgeons. I've started patient on pain relief, antiemetics, antibiotics, but I just need an assessment. I'm referring this patient mainly for an ultrasound and for surgical review. If you're referring to your colleague, then it's quite the same. So you tell them what exactly is the presenting complaint, history of presenting complaint, what you've done so far. If this patient has been admitted, just mention which department they're under, and what is the management plan. Usually when you're handing over to your colleagues, if a patient has been sorted out, they've already started the management. So there's nothing really for your colleagues to do except just for them to be aware. If you feel like anyone might deteriorate, a more complex case or someone that needs anything done, so please just mention it towards the end. Okay, so don't forget the SPAR approach. It's basically what we use for referrals and for handovers. Now, in ED, we have specific ED guidelines that you can actually find on the computer system. So when you're starting your clerking, when you're logging into any computer system that you're using, at the very up part on the computer system, you're going to find something called ED guidelines. And if you press on them, you're going to find it sorted out by different cases and by alphabetical order. So for example, angina, A, you're going to find under A few things such as angina, and then B, you're going to find a few things just as bradycardia, for example. So the ED guidelines are really, really good as a summary and for you to know what you need to do. If you can't really find your ED guidelines, then please ask, because most of the trusts, they have their ED guidelines in the computer system. If you're a paper kind of situation, then maybe you're going to find these on the intranet apps for your trust. Of course, we all follow the NICE guidelines in CKS. If, again, we've mentioned this before a few times, but if the patient's coming in with any kind of toxicity or overdose, ToxBase is the application or website that we use in order to know how to manage these patients and what is the monitoring needed. So just be aware of the different applications and different computer systems that we use, different websites, such as NICE, BNF, ToxBase. The intranet is the trust website. If you can see the biggest image on this slide is the trust intranet. And the trust intranet does not only cover the guidelines, it also covers a lot of other stuff like your pay slips, your emails, your rota. So a lot of things are going to be on the intranet. It's good for you to know to be well oriented about it and to know exactly where to find things, because then it makes it easier for you to go through the trust intranet. So if you want to have a play around it during your induction day and just know where every link is at, that would be a good idea. Now there's something that we've not mentioned before in our previous videos, and it's called Datix. So if you can actually see it, it's right here on the Trust intranet. And Datix is a term just for you to be aware what exactly it means. Datix is basically an incident reporting system. We use it in all the NHS trusts, and we use it in order to make sure the patient safety and the staff safety are handled well, and for the organization to investigate anything that goes wrong. So what does it cover? It covers any incidents that have happened for patient safety or staff safety, like any medication error, any, for example, falls that a patient has gone through, any delayed care. This all gets datixed. Any near miss kind of harm, like for example, you've given a medication that the patient's allergic to, so but one of the nurses picked it up before the medication was given, so this is a near miss. It could have caused harm, but it didn't. Needle stick injuries are datixed as well. Any risk hazards, anything that's happened that caused any risk, any harm, any complaints against you. So for example, there was an incident where, let's say you came off a bit rude or you came off a bit aggressive with one of the staff members, or it was witnessed by a staff member against a patient. All these things get datixed. Okay. So when you hear the term datix, for example, someone tells you there is a datix in your name, just know that it might be covering one of these stuff. So don't panic. I find a lot of trainees or a lot of, non-trainees, when they're new to the NHS, they panic quite a lot when they hear the term datix. Datix is not a major incident. So it's just minor stuff that we learn from. Any major incident kind of stuff, it has a different, protocol. So any serious incidents they would get datix, but they all would also go through a different system. So when you hear the term datix and they're requiring you to, set up a meeting and have a discussion, just take it easy. Make sure you're calm, make sure you're addressing this with an open mind and just saying exactly how the incident happened, what exactly happened. And then, it's a learning event. So it would be a good idea to put it in your portfolio. If you're a non-trainee or a trainee, you usually have a portfolio. So make sure you just put it in in your portfolio and just learn from it. Because at the end of the day, whether you're a junior doctor or a senior doctor, we're all still learning. So my advice would be, again, don't panic, take it easy, and just, be honest about what happened exactly. Okay, so we're coming towards the end of this, introduction to emergency medicine. And at the very end, we're going to discuss a few cases. So these are the cases that we're going to cover. These cases, we're going to clog them together and we're going to hand them over as well. So, just be aware about these three cases. These are one of the most common cases that you see in A&E department. So, a patient that had a fall, elderly patient especially that had a fall and had any sorts of injury, or had a fall and did not have any injuries. So this is what case one refers to. So fall is something that's very, very common. You're going to see on a daily basis in A&E. Um, Another stuff that you're going to see very common in A&E is your TIAs and your stroke. Anyone coming with weakness that's lasting still or has actually resolved. So case two is basically what is going to cover that. And again, it's very, very common. You see a lot. I would say at least weekly, you're going to get someone who has had like a weakness or a symptom. And then you have your chest pain cases, of course, chest pain that are musculoskeletal, chest pain that are actually serious chest problems. So whatever age you're gonna get chest pain complaints from them. Make sure you're oriented with these cases. Of course, other stuff like abdominal pain, mental health cases, all these are very common, but we're going to clark these three cases together. Now, I'm going to make it in a separate video so it would be more clear to you and you can easily follow through. So we're going to, in the next video that I'm going to post, we're going to clark these cases together and we're going to hand them over and we're going to discuss exactly how to handle them and how to manage them, okay? So I hope this video was useful for you. If you have any questions, just send it through to our official email and we'll be happy to answer it through. And I hope you benefited from this video. If you've done, please just, subscribe and like. Okay. And thank you so much.